Good evening, everybody. Welcome again to another episode of National Fellow Online Lecture Series. This series of lectures is sponsored by AMSSM, Fellows Online Educational Subcommittee, the Educational Committee, as well as the Fellowship Committee. It's with great honor that we have Dr. Bill Meyers that's going to be speaking to us today on growing pain in athletes. There's an upcoming talk next week on chronic exertional compartment syndrome. And the speaker is Dr. Landon Mueller, and that will be moderated by Dr. Goldberg next week, 11/19 at 8:30 p.m. Just as a reminder, this talk serves as an adjunct to individual program educational lectures. It's supposed to provide fellows with direct access to educational experts, as well as AMSSM members with variety of different guest experts, as well as a variety of different formats. And also another goal of it is to kind of help with the CAQ examination preparation. Just a few housekeeping rules as usual. Please make sure you mute your microphone and turn your video off during the course of this talk. Please submit your questions you might have through the chat function. And if you wish to, you can include a little bit of information about your name and what program you are. At the end of the talk, I will ask the questions to Dr. Meyers. And at that point in time, you will answer those questions. Oftentimes we do some of this evaluation, but if you have any conversations, comments, or questions for us, please feel free to reach out on the website to ask some of those questions. So earlier I was talking, I've heard Dr. Meyers speak maybe about 15, 16 years ago during my residency in Philadelphia. So I'll do a quick introduction about this esteemed surgeon that's going to be speaking today. Dr. Bill Meyers is dedicated more than 40 years pioneering diagnosis, treatment, and rehabilitation and prevention of core muscle injuries, also known as athletic pubalgia. He founded Vincera Institute in 2010 and is a leading authority in this field. He has seen more than 50,000 patients with core muscle injury. He graduated from Harvard University and Columbia College of Physicians and Surgeons in 2003, and also received Master's in Business Administration at Wharton School. He trained at Duke in cardiothoracic, general, as well as vascular surgery, and did some bench research in liver physiology while there. He has published over 300 publications and has had multiple of them funded with the RO1 as well as the VA Merit Review grants. He wrote the first paper in laparoscopic cholecystectomy and published in the New England Journal of Medicine, and has also had 10 years of multi-million industry grants. As surprising consequences of his hobby, he became seeing many patients with mysterious disabling pain in what they call core muscle injury. With his colleagues and a fresh cadaver lab, he was able to kind of figure out some of the intricate details of dysfunctional anatomy. He wrote a book called Introducing the Core, Demystifying the Body of an Athlete, has become a Bible for understanding core anatomy. His co-editor, partner, Alex Paul, certainly is a person who is the second most experienced in this field. I'm assuming that's next to him being the number one. The Vincera Institute is in Philadelphia Navy Yard, and now has become a place to go for leading athletes in the world in the diagnosis and management of core muscle injuries. So Dr. Meyers, thank you very much for granting us and blessing us with your presence today. I'll stop my share and we'll have you share your image at that point.
Okay. What I'd like to do tonight is really go through some of the important principles in terms of what I call the core, and really we're talking about the area from mid chest to mid thigh, nipples to knees, and and that's the unit of the body that we're talking about. And so I really would like to really get into how this field started, and then I'll mention several of the key anatomic principles in terms of understanding it. And I'm going to sort of dot the presentation with a number of fun observations that have been made over the number of years that I've been involved in it. And I really do have to start off with my background. I spent most of my life, academic life, at Duke University, and I'm not an orthopedic surgeon, and I may look like one in the sense that I'm fairly tall and kind of cloddy when I walk and stuff. You know, look like an old ex-athlete with limps and stuff. And the but I'm trained in cardiothoracic, general, and vascular surgery, and had really uh, the busiest liver program in the country for many years, a lot of my work really has been focused on basic liver physiology, and we would be doing like 10 or 11 liver resections per week, one or two transplants. We started the third liver transplant program in the country, and well, even after the good preservation solutions came in, which allowed you to operate at a decent hour in the morning, we didn't like that because that was when our elective schedule was going on. We really liked operating in the middle of the night. Now, purely as a hobby, and this really began in the mid 1980s, and through friendships, orthopedic folks, when Mike Krzyzewski, the Duke basketball coach, who's I think the number one winner in terms of games there's ever been. When he came to Duke, he moved right in a few houses away, and he was really attacked because his first few seasons were horrible, and he knew all the time that had recruited really a super team and was very confident, but they're actually trying to get rid of him, and but it was in this neighborhood we became really close, as did a few other folks with us. His three daughters. On his right is his eldest daughter, who was our babysitter for years, and then Lindy on his left, and who would fight with my son on the way to school, and when we carpooled. That was usually my wife. It wasn't me, but she was in love with my son, and my son wouldn't even look at her, and so that became a subject that we talked about a lot. And Mike, through his friendship and stuff, he got me interested in covering some of the teams at Duke, knowing that I had a sports background and stuff. But as I mentioned, I'm not an orthopedic surgeon, and I was involved with basic liver biliary stuff, and was having a large program in the South and all that. The person who really started laparoscopic cholecystectomy was a fellow in Nashville, Tennessee, and he was actually labeled a quack by one of the editors, co-editors of the Annals of Surgery, and an editorial was written from this person who's across town at Vanderbilt, saying that he was a quack, and the whole idea of operating through small incisions rather than big incisions, where you could really expose things well, was welcomed unwelcomely by the status quo in terms of surgeons, and I decided early on, because this fella who is doing some laparoscopic cholecystectomies invited me to to watch him do it. And I quickly put together a group of surgeons in the South, about half academic, half private practice, and did a prospective study on lap chole. This is 1987, 1988. And a little bit after I started covering teams and things. And I ended up writing a paper in the New England Journal. And but before doing that, I presented it to the American College of Surgeons. And this was me after my first presentation. I got absolutely stabbed by folks saying this is like the worst thing ever. And so I'm used to taking hits. So feel free, anybody in the audience now or who may watch this on tape afterwards to hit me hard. I can do it. I can take it. Now, in terms of lap chole, and then we developed a lot of the initial procedures in terms of lap colon resections, lap hernia repairs. We I was a guy that suggested using mesh, which I regret a little bit because that's the only way you could repair these hernias um, from inside the belly. And we, we were watched. Every move we made was watched by folks, and we did the first Nissens, and we had the Queen of Saudi Arabia come over. We did a lap-assisted colon resection, and so we were quite well known in that field. And the main problem with doing some of these minimally invasive procedures was that each had its own Achilles heel, and the Achilles heel with laparoscopic cholecystectomy was bile duct injury. But we got through all this because patients recognized how important it was, and they could, spend less than a day in the hospital and get back to their work and stuff in a magnificently short time. And so we had that going for us, and we were doing exactly the same thing as we were in an open situation, taking out the gallbladder. The problem with hernia repairs is that we needed a new way to repair them, which involved putting mesh in, and that's sort of been a problem with respect to these core muscle injuries. The article in the New York Times on that was written by somebody who had undergone the surgery, laparoscopic cholecystectomy, was probably had more impact in terms of this catching on than our paper in the New England Journal. But the New England Journal article really legitimized the whole thing. The Achilles heel was bile duct injury. There's a picture of that where basically the cystic duct is misidentified as the common duct, and you take out a chunk of the biliary system. Now, this field of core medicine is really, really important, and it has been brought to me a totally different type of frustration. And what I want all of you to recognize is that this requires you're putting on new eyes. That you can't especially look at your at sort of the periphery of what you have learned, because most of what we learn is really empirical. It's what our teacher told us to learn, and the whole idea of watch one, do one, teach one is not applicable to this. You really have to have a different recognition of the anatomy, and the anatomy is real. And if you keep on just focusing on the anatomy, you'll get it, because it's very different than a hernia. It's very different than what a lot of people have been looking at and saying, oh, this is just an injury here. And it just happened to have an injury on the other side of the groin or the other side of the abdomen. And these are real injuries, and there's a understanding of why they occur that we have. we can certainly do a lot more research, but most of my research was in the laboratory, a fresh cadaver lab. It's important for it to be a fresh cadaver. And this is something really I call my eureka moment. And I was covering several of the teams, and we just finished examining 3 people in the field house. At Duke, there was a field house with a set of examination rooms, and in each case, the pain had traveled. Can you hear me okay? Um, had traveled from the abdomen to the adductor region and was kind of fleeting. It would go from one side to the other. And the big question, and as me and one of my sub interns, she's depicted there with a tear in her eyes, and I'll get to that in a minute. We went straight over to the fresh cadaver lab and really decided to do an experiment, which was trying to elucidate why does anatomically would someone have something that starts above the pubic bone and then the pain would go below the pubic bone. There really was very little understanding of what connects the top to the bottom. So I had her put her finger behind the 3 adductors. And even though it looks fairly close here, it was she was really 6 inches, 8 inches down from where I was in terms of where I was about to cut the muscle. And her finger lay on top of the anterior edge of the inferior pubic ramus, which has some teeth to it. And before I cut like 30% of the rectus abdominis muscle above, I asked her to just let us know, and there's several people observing, if she felt anything. And as soon as I cut that degree of the lateral edge of the rectus abdominis muscle, the pelvis tilted. We could feel that. And those teeth rammed into the back of her index finger. And she let out a scream, and she really did start to cry. And but everybody who was watching was excited that it was pretty obvious that we had done something to the lower part of the body that had caused these tears. Her finger got better, but we realized that there was real connection between the rectus abdominis muscle and the adductor muscles, and and it turns out that it's the cover. There's a fibrocartilage cover, the pubic bone, that is the connection, and it's fibrocartilage. This used to be called the common tendon of the 3 adductor muscles on each side from below, but it really covers the entire pubic bone. And we'll get into this a lot more. Now, we subsequently, it wasn't until I really got to Philadelphia, a fellow named Adam Zoga, who is a radiologist who had done the imaging on a quarterback, old quarterback of the Eagles named Donovan McNabb. And I was not part of the Jefferson system, at least not at that time, and I was critical of the imaging, and Adam had done the read, and instead of his getting mad at me, he called me up, and I thought he was going to really get mad at me because I was really quite critical. He said, "Tell me about this stuff," and I did. And emphasize the importance of fresh cadavers. This is a relatively fresh cadaver that Adam dissected. And so what we did was we actually brought these cadavers, or several of the cadavers, over to the outpatient imaging center in the middle of the night. And so don't report me. I guess I've already blown that, but because we'll be on YouTube or something. But we were able to figure out ways to image this area really well, and it really comes down to understand the planes in terms of where the tissues insert, and to do a rotating plane so you can see the entire insertion, and magnification and placement of the receiver is really, really important. But most of our observations came from that. Um, and what we're talking about is this, the analogy is the baseball. And instead of having a leather cover the baseball, it's a fiber cartilage cover the pubic bone. And it covers the entire thing, front and back, lateral. And the muscles, as you can see, the rectus abdominis muscle from above, the three adductor muscles from below, all insert into different parts of the cover of the baseball, fiber cartilage cover of the pubic bone. Now, there's a very thin aponeurotic layer, and one of the things we emphasized early in our radiology papers was that the aponeurotic layer was important. It really is not as important as the thick fiber cartilage cover of the pubic bone, and it really feels like the cover of a baseball. Now, the same fiber cartilage goes into the symphysis pubis, and the anatomy is way different in terms of the symphysis than what it's been reported to look like. People usually report like a disc like you have in the intervertebral or the vertebral area. And it's not, it's this fiber cartilage, and you have fluid, a little bit of fluid up top. And the radiologists have sort of commanded the terminology when they talk about a secondary cleft, et cetera. The primary cleft is that normal little white thing in between the two sides of the pubic bone. A secondary cleft is purely a radiologic term, and they would call the fiber cartilage the black that surrounds the pubic bone on certain images like T2 or STIR. They call that the common tendon. And we realized that we've got to get rid of some of this nomenclature and just again, just speaking purely anatomically. Now, the frustration part of all this is that people can't get out of the world of hernias, and they can't get out of whatever other world they're in. And that's been really frustrating. I mean, you just can't work in the periphery of what you know, what your eyes see. You've got to put on new eyes. And the same is true for things like a lot of you all, I'm not being accusatory, just making an observation, are really getting into the stem cells and PRP stuff. And we found that PRP in this region causes a 60 to 80% chance of heterotopic ossification. And it's real. And we had a paper in the American Journal of Sports Medicine just a little bit over a year ago on this, and we had 78% of the football players, NFL players who had this developed heterotopic ossification. And this is just one example of what it looks like. And people are just falling into these traps because they just don't understand the anatomy. They don't understand the basic principles, and they jump to conclusions really quickly, and they're not really taking advantage of the fact that this pathology, pathophysiology, anatomy that I'm talking about tonight is not well known, and it needs to be spread. And and then you can really get into it in a much more scientific way. We use a lot of PRP and stem cells, but not in this region anymore. And we've gotten pretty much the entire NFL not to do it. And this just shows you that there's so much. Basically, what we're seeing is the end stage of scar formation, which is calcification. And when you have to remove that calcification to get the person back to play, sometimes or even without removing it, you may, if you've been giving PRP in this region, you'll see these indentations, which are really quite profound. And the ones that I may show you, this one in particular was not causing any harm because we had removed that huge calcification. My first paper on this was presented in 1989 at the American Journal of Sports, at the Society for Sports Medicine, and published in the American Journal of Sports Medicine. And we just didn't want to use the term a sports hernia because they weren't hernias, and there are too many people doing hernia repairs for this and putting mesh in, et cetera, already. And so we made up the term athletic pubalgia, which is a vague term. This is the paper where we introduced that. Dean Taylor, who was president of the society 2 years ago, who was basically a first-year orthopedic resident who I recruited to write this paper. And Dean was the only one who volunteered. I couldn't get the general surgery residents interested at all. And most of the orthopedic residents were not interested, but Dean volunteered and did a great job. And the problem with athletic pubalgia turns out, which I mean just means it's a vague term meaning pain around the pubic area in athletes. Yeah, the problem with it was the syllable pube, that we couldn't get the media to get rid of the term sports hernia, and because they wouldn't say pube, and so that ended up, after several years of frustration, going by the wayside, because what I did was I had a bunch of the athletes, Adrian Peterson, Greg Jennings, a few others, not answer questions when they had press conferences about this, when people used the term sports hernia, and instead they insisted on using the term core muscle injury, which really is a much better term because that gets people to ask what muscles you're talking about, and that's the right question to ask. So the right term really is core muscle injury, and there's a whole bunch of muscles in there, and they have different ways to attach, et cetera. And basically, when involving that cover, the fibrocartilage, I call it the pubic plate, often you do really have to consider, really most of the time, you have to wonder if surgery is going to end up being the right way to treat this. When you have more peripheral injuries in the muscle, et cetera, usually you don't have to operate on. And for example, I was the main guy covering the Eagles one preseason, and we had 13 core muscle injuries, and only one of them was really involving that pubic plate, and another one actually evolved, so it was. And we were able to get everybody through the season, and most of the time the injury resolved, except for those two players. And one we didn't operate until the end of the season, the other one we operated on during the season. So most of the injuries, the groin pains that we've seen in sports really do not require surgery. Now I got frustrated and published a whole bunch of stuff, a whole bunch of papers on this, but it seemed like nobody was listening. And one of my goals was to get this into the mainstream of medicine, and just couldn't do it. And so I decided I'm just going to put this all um, into a book, everything that I could think of. And so, I have a bunch of really good co-editors, Mark Philippon, who's been really the leader in developing the techniques of hip arthroscopy. Then Adam Zoga, who I mentioned, Alex Poor, who's been my partner, Johannes Rodel, who's a radiologist who's just been terrific as well. But the first half of the book is really the original stuff, and I put as many of my observations from the lab, from the fresh cadaver lab, and other things that we had done into this book. And so I'm going to give you a few of the principles that I think are important. This is the person who we were going to have on the cover, and interestingly, this is Marshawn Lynch. And Marshawn really wanted to be on the cover with this picture. But the folks who owned the property rights for the picture wouldn't let us do it, and then came back and said, hey, can we do it in another edition? We haven't decided about that yet, but I think we probably would get more. I mean, it's been a popular book, but I think we got even more readership with having that on the cover rather than what we did, that picture, the book cover that we snuck into Alfy's shower and took a picture of him. So I think Marshawn, no offense, Alfy, but I think Marshawn might have sold better. Now we see, I'm just going to show a couple of the studies we did. One was did almost the same study where you cut the rectus abdominis muscle about 30–40%, and but put a needle into the hip joint. And now these are not live people, so um, um, so we couldn't do physiologic measurements. But as soon as you did that, the pressure inside the hip joint just went zooming up. And we did this with various types of strain gauges and other things, and it would usually bend the needle. And so we realized there was a profound relationship between these core muscles and the hip. And the same thing was true in terms of the rectus abdominis or the adductor tissue when you cut that. But we did a bunch of experiments just trying to show the range of motion of the hip other than the ball and socket hip joint, which is really the way most orthopedic folks thought in those days that the whole world was in that ball and socket. Well, it's not. And the adductors are really, really key to that range of motion, but so are other anatomic staples in there, like the femoral triad goes right over this area, and that's one of the sturdy, stabilizers of the hip. So the hip is a lot more complicated than we give it credit for. We did a whole bunch of studies too, in terms of just figuring out the forces. And these arrows really come from the size of the muscles and the volume of the muscles and the direction of forces. And it's really important to understand that when you're doing the surgery, because the reconstruction of these muscles when they are injured is, of course, important. And you want to simulate the normal pressures and forces. And we also realize that what's going on one side is usually to some degree going on the other side. It's either through direct anatomy or through compensatory types of things. This is a paper that I helped write with one of the HSS fellows who's in Chicago now and one of the team docs for the Chicago Bears. And it really shows how, if you consider the socket of the ball and socket hip joint, that and the bump that you get with cam impingement, that that it really rocks the central area, including the pubic bone, so that you end up with enhanced femoroacetabular impingement on the other side. And there's a whole bunch of sort of cyclical things, circular things, circular mechanisms that really do show the compensatory nature of this or the actually direct anatomic nature of the relationship between one side and the other and the relationship between the muscles and the hip. And it's really important to realize this, that there are two lines of stability or two concepts of stability that are really important too. For the hip joint, there's a whole bunch of layers, muscle, ligamentous, et cetera, layers, which provide stability to the hip. And for the whole pelvis, the same thing's true, that the pelvis with all the small bones and the three big bones is something which can really become unstable. And the primary consideration in my mind when I see a patient and examine the patient with groin pain is what is unstable to some degree. And the choices are really between three things: the hip, the core muscles, and other things. And so the when I'm teaching students or fellows, et cetera, they have to, when they first examine a patient, I want them to come up with one of those three categories, but they can name more than one, but they've got to be right too. If hip and muscles can occur, hip and other things can occur. And so it's important to consider really that whole part of the body. So think nipples to knees, think this is a real unit of the body from a musculoskeletal standpoint. The other thing is that there's really in terms of from the top and the bottom, there's really relatively little tendon in terms of that attaches. It's really muscle going onto the fiber cartilage. So when people start talking about the tendinous structures, listen to someone else. It's muscle going to tendon. We've done a lot of studies of that. And so basically things start with some type of a shredding one of the muscles somewhere. And then you get a tug of war on the muscular attachments under the bone, and then things start to separate. And once they start to separate, you're in danger of pulling things right off, pulling the muscles right off. Now, this A here, which is to your left, the patient's right, is really a normal appearance of the pubic bone, and the black around it is the fiber cartilage. And you don't really see much extra white in there. And of course, when tissues separate, you're going to put fluid in there, and that is the injury. And B, you can see the injury. You can see this this tangled line that is really a block of ice that's cracked. And once you get a crack that big, you're going to have some degree of instability. You can see some fluid in the adductor muscles there too, and that fluid will actually leak out. Here's a well-known linebacker, defensive end, who was hurting for a month on the right side. And you can see this little crack on the right side in that fiber cartilage. And then during a playoff game, and he was having a great game, it was the opposite side that ripped right off. And you can see the chunks of fiber cartilage that migrated distally. This is all during the game. We saw them the next day and operated on them the following day. And you actually can figure out the tangle of anatomy when they rip things right off. And if you operate on them right away, you can really fix them all the way. And he's a good example of that. But basically, this is a rupture, an avulsion of the left pubic plate. And this is really based on that, what we were seeing. This we found intraoperatively. And you really just have to bring things back together. And you can see that the adductor longus and the pectineus are off together. The brevis was off, but more distally. And there are multiple areas in the muscle that were partially torn. And so it's a matter of just really identifying all that. And you can identify it when you get in there early. But the primary issue, the primary culprit was on the right side. And you can see that there's a sort of a chronic scar on the rectus abdominis side. Often it's the rectus abdominis muscle that separates first, and then the adductors and the other side end up being the compensatory side. Again, another picture of the same thing. In order to get it up there, you have to be really aggressive of in terms of cutting through the fascia and other layers that are thick layers that we usually call epimysium. So it's really a combination of loosening the tissue, the fascial tissue, and you have to go all the way down to their distal insertion sometimes to get it all the way back up. But if you get it operated early enough, you can do it, and it's a matter of sewing things back together without tension. And it's all very, very accomplishable. As you go farther and farther out from the injury, there's more scar, but you can still do most of these reconstructions. Now, I want to take a step back and let's just consider the anatomy. And this is not Alfy in the shower. This is Da Vinci's model, and which comes from earlier dissectors. And this is your core. This is the core. There's a lot of stuff in there. And this is the way I want you to think about it. I want you to think of it in terms of mid-chest to mid-thigh. And think of it in four ways. Think of it in terms of, if you go from A, we're talking about in A, the back and the chest. And that's part of it. In B, we're talking about the hip joint. In C, we're talking about all the skeletal muscles. So all the skeletal muscles in here, consider those core muscles. And then D, you're talking about everything else that's in there. And there's some serious stuff in there. So you got to be pretty savvy in terms of like Crohn's disease and endometriosis, which are the most common things that we see that can be confusers in these young athletes in terms of that age, both in males and females. But there's a lot of stuff that can occur in there. We picked up a whole bunch of cancers over the years. And so you just got to keep your antennae up. So it's core muscles, hip, and other stuff, or a combination of those two things. We call the muscles that are closest to the pubic bone the harness muscles. So think in terms of this being what your brain talks to. And if you're shifting and stuff, your brain's talking to that. That's causing you to give your deep fakes and the running back in football. Those are the ones you want to protect. Now, these are your second lieutenants. These are the ones that then tell the power muscles what to do. And these are the power muscles. So divide them into harness muscles and power muscles. And this is the way to think about it. Now, there are other muscles too. And this is M&M pointing out the insertion of the lesser trochanter, the psoas muscle onto lesser trochanter. He was doing that, of course, in public. But we call this the psoas muscle the M&M muscle because either you love it or you hate it, but everybody agrees it's important. And in another sense, it can imitate almost anything in the pelvis, any type of injury or any type of disease process. He can imitate it, and so Slim Shady is the one pointing out that lesser trochanter insertion site. This is Slim Shady in the back, representing the psoas muscle. And so when you think maybe adductor or hip, you got to remember about Slim Shady. Think of the rectus femoris muscle as the Rodney Dangerfield muscle. It's the biggest muscle in the in the thigh, and besides the hamstring, certainly in the anterior thigh, and it's important. And if you rip off the rectus femoris muscle at the insertion site, you lose the command of your muscles in that region, and you create a real instability. And it's a real setup for hip problems, for other muscles to get involved. There was a paper that got a lot of publicity from the NFL data bank, where they reported, I forget what the number was, it was 8 or 9 patients with it, saying they all got back to play. That's baloney. One of them got back to play. Even the pro band ended up having to have his hip fixed. He developed tremendous heterotopic ossification of his hip related to his rectus femoris being off. So all the other ones were not able to get back to the NFL. And so there just anecdotally and several papers out there now recognizing the importance there. We've learned to be able to predict avulsion ruptures, and this Deshaun Jackson had a very predictable one a few years ago, if you remember that story. And we learned that if you look at figure C here, if you have a line that goes right across that fibrocartilage, that white line goes all the way across, and you have edema that goes up into the rectus abdominis and the adductor area, lots of edema, you can predict this is going to be an avulsion, and he's going to rip it right off. He's going to rupture it right off. And that's what Deshaun did. He could straight line run pretty well with some rehab, but then in his first set of downs back, he just ruptured it right off and ended up missing the playoffs. But when he could have had this repaired earlier. This is what heterotopic ossification looks like. It's a lot of black and white stuff. It looks mottled, and we're seeing that MRI is a good way to diagnose that. This is the paper that I mentioned to you before. There are 28, actually 29 NFL athletes who had previous PRP treatment. those 28 underwent surgery, the 29th did not. And you can see in there that there was actually a 78.6% chance of heterotrophic oscillation. They all had tremendous fibrosis. So be careful with that. And what we did was we wondered how many patients had gotten PRP that we weren't seeing and may have done okay. And so we were able to research all that by talking to the team docs and looking at each team's private data. And there weren't any patients we could find who really did well with PRP. Now, that's sort of a spotty study, but we were able to track down almost everybody, and it's not a good thing in this region. But people are taking advantage of this. This is someone called the Chinese witch doctor who is actually from Brazil, and he actually he's from Argentina, and he practices in China, and he's really just pumping PRP and stem cells into folks, and he's gotten a good reputation, which is now a bad reputation in terms of what's happened. When you get in there surgically, things may look pretty good here. These are some adductor muscles, but when you go deeper, you realize there's a big hole in there, and that may be a rupture. But even when there's a gap of like an inch here, you can go reach down and cut through the scarring and cut through the fascial planes and bring things back together. Now use these. The orthopedists are now finally using these principles, like with hamstrings. If you can go way down distally, you can cut through some of that fascia and do your repair of the proximal hamstring, and get people back in a 6-week type time frame, sometimes 8 weeks, but not the 3 to 6 month time frame. But if you're going to try to sew it all back and with bone anchors and stuff, with tension there, it ain't going to work. Same things, applicature of the rectus femoris muscle and the Rodney Dangerfield muscle. Repair it, and if it's up at the proximal insertion site. So my final message to you is open your eyes as wide as you can in terms of appreciating that this is real anatomy, this is real pathophysiology, this is demonstrable, these are demonstrable injuries on MRI, but get new eyeballs and don't rely on the periphery revision. Learn this stuff. This is one of those unseeing types of things. Unsee the hernia and whatever way you've been thinking about these injuries and learn this anatomy. And you'll find out that all this stuff, if you go to the literature and see all this baloney that's in the literature, that's goulash. But we really, if you go to the book, you'll really understand that this is real stuff and is demonstrable and really is the reason why we've been successful, certainly as an institute, in terms of not only with the results of the players, but it's finally catching on. And it's really a privilege to talk to you all. You're young, upstart folks who are in the right field, and keep on doing it. But wear your scientific hat. Don't all the time. Don't fall for this cash payment of PRP and stuff. And if you can stay out of the mess in terms of the competitiveness in your field, and just stick to anatomy, I think you'll do well. Thank you.
Thank you very much, Dr. Meyers, for an awesome talk. I have 1 or 2 questions, and just a reminder for the audience, please feel free to type in your questions on the chat function, and I will ask. So, Dr. Meyers, my question is, when do you recommend non-operative treatments, and what are some of the criteria that makes you maybe suggest that this particular injury or this particular athlete will do okay with your recommended non-operative treatments?
Yeah, and that's a broad question because there's a whole bunch of different injuries, and you have to consider the specific injury. You have to consider the importance of sports to that person. You've got to consider in an elite athlete or an enthusiastic athlete, things like where are you in the season? Is this begin preseason? Is it the beginning of the season? Is it the middle of the season, the end of the season? And and if you just take the elite athlete, just talk about the elite athlete, and of course, as you get older, just like when you have an ACL, which I still have, which was removed when I was playing soccer, still played a couple of years of soccer at a high level and played professionally, um, but without an ACL. But I don't want to get an ACL reconstruction now. I mean, I'm too damn old, but I was too damn old, 20 years ago. But so even with the severe injuries, uh, there's going to be different attitudes depending where you are in life and what you're doing. The With the athlete who has something that really looks like it needs to be fixed, where it's really ruptured, the attitude and where they are in the season is really, really important. Now, also, you got to take into consideration that the agent is usually is gonna side with the player, not always. And the management's gonna have a totally different attitude about it. And if you take Lane Johnson, a tackle, I just mentioned people who've been in the press and who allowed us to use their names, but he ruptured his pubic plate profoundly on the left side with a big 4-inch gap. But this occurred like 2 or 3 weeks before the playoffs. And it's going to take you 6 weeks to get back if you repair it right then. So what we did was we got him through the season and the end of the playoffs. He made it to the Super Bowl, played really well for not really well for him, but really well for the team. And we fixed him afterwards. And you can still fix it. You can still fix them. But there was no reason to do that. Now you have all kinds of different attitudes too, like Sean, the coach of the New Orleans Saints, now with the Denver Broncos, Sean Payton. He wants to get all of his injuries fixed before preseason, if he can. So you'll have different attitudes from the coaches, from the general managers, et cetera, of getting things fixed early. I mentioned that when you're covering the Eagles, that there was a whole bunch of patients who had core muscle injuries, but none of them were, or two of them turned out to be serious, but most of them didn't. And so the concept of operating on everybody is a dumb concept, and because there's a whole bunch of different types of injuries, but you've got to take into account those different factors, and you still have a couple of old time NFL guys, team physicians, who think like the old time coaches. Back in the old days when I was playing sports, the coach was the team doc, and if you had a groin problem, Richie Zaro at Harvard was the main guy that I think about there. They just thought he wasn't tough enough, and it was the coaches. The coaches would not give him a chance because he just wasn't tough enough. He had a real injury. I don't know at that time. I didn't know what he had, but he had a locker right next to mine, and I can bet in retrospect what he had. But you've got to think of who the people are, who the docs are, and you all in family practice and PMNR who are getting into sports medicine are really coming into the right field. I mean, you're driving this already. You're starting to drive it in terms of the attitudes, the recognition of what real injuries versus not so real injuries, and just realize that you're in the right field.
Another question is, what is the male to female ratio of this disorder, and why do you think there's such much difference in the ratio?
I'm sorry, the ratio of what?
Male to female, in terms of
Oh,
this
yeah,
condition.
that's very interesting because I started this before Title IX, and we had probably 5 or 10% of the folks were female. Now that went up to about 30% after Title IX. So a lot of it was just not participation. But but still way more males in terms of these particular injuries. And then when we considered hips as part of this, that's where it started to equalize, but still there are more injuries in the males and females, even with the hip issues. And I'm convinced it really has to do with the same angles to a large degree as how you explain the ACL injuries in terms of that, why that's 3-to-1 or 2.5-to-1 or whatever it is, female to male. In males, there's a much broader base, so that angle doesn't play as much role in the hip and the knee issues, but it provides a stability of the hips and the knees, so the muscles take the hit. And it really is the narrow pelvic guys when we analyze folks who are often the cornerbacks, the defensive backs. And often the defensive backs are a little bit smaller than the wide receivers. The wide receivers go out and they know where they're going, and the defensive backs got to react to it. And the fellow with a narrow pelvis really does get these injuries more than the broad-based folks. And so I think the male-female stuff is really the basic anatomic differences that you've identified, that the orthopedic folks have identified in terms of the different angles. The flatter you are, the more broad-based you are, the safer you are from ACL stuff, but not the core muscle injuries.
The next question is, does physical therapy help with these patients who do not undergo repair? If so, what do we direct physical therapy to focus on any type of guidance for rehabilitation?
Yeah, we have a bunch of different protocols in for example, today there's a football player, one of the NFL guys who really wants to play the rest of the season. He's hurting, and you can inject him with steroid, and that's not going to do anything in terms of healing. And these things, once you get a severe central injury, pubic plate injury, they don't heal. And so the key to it is to get him through the end of the season. And now for him, the principles are to get rid of the pain that's related to the inflammation, which is what you do with the injections, but then putting them on the right rehab protocol. Now, they're in great shape to start with, so they don't need to be rehabbed more before they go back out. You give the injection, you wait, usually it's 3 to 7 days when they're really starting to get the max effect of the steroid injection. But the principles of rehab really are some of the main principles. You really focus on building up the power muscles, and you stay away from the central muscles. You don't try to strengthen those harness muscles, because all you're going to do is create more damage. And the Terrell Owens, Herschel Walker workout regimens of doing 1,000 sit-ups is totally crazy. You're gonna and the ab roller is one of the big culprits. I think it's advertised at 3 o'clock in the morning when you're having another cup of coffee trying to stay awake. The don't try to strengthen the central muscles too much, and strengthen the other things, and then you can sneak back in on the central muscles, but you don't need to put those through rip-roaring workouts. And stay away from isolated things. Stay away from isolated adductor, isolated sit-ups, of course, would be isolated stuff. Same with hamstrings. I disagree with we have some conflicting data in terms of what FIFA's come up with. You don't want to strengthen the hamstrings. I mean, those things, all these muscles are going to weaken in the course of a season, and that's been demonstrated really multiple times. So you have to figure out what you're really focusing on in terms of physical therapy. Physical therapy has great roles in this stuff, but it's not going to cure the patient with a big insertional injury.
I was wondering if you could comment. I know you mentioned steroid injection. I think there's been a lot of data in the literature describing chondrotoxicity of the cartilage, maybe slight increased risk of tear. So how do you recommend folks, people that get steroid injection, do you still recommend that? And the second part of the question is I actually saw a patient this week had a acute injury about 6 months ago, and he's not received any type of injection yet and did have some early findings of calcifications in the form of heterotrophic calcification. So are there other scenarios maybe there could be without orthobiologics that patients could potentially have this calcification?
Yeah, there's two scenarios I'm seeing most of the calcifications in, and the one is with the biologics, like you talked about, like we talked about. The other is with just chronic injury, and usually it's a pretty severe chronic injury, like a rupture, like you're talking about, um, and this really comes is very consistent with massive casualties, massive wound casualties. They taking care of a lot of trauma patients and working a lot of military folks over the years, the massive casualty patients almost all get heterotopic ossification, even if it's multiple wounds. And you're circulating. I mean, you got to be circulating the same um, stem cell or stem cell stimulants for healing and in terms of all this. So um, it's what you describe in terms of that patient is expected. Now, also realize that if you can, usually you can remove the big chunks of calcification and you can fix it, but sometimes you can't. In our paper, we mentioned there were several high-level pro players that we just who really lost their careers due to the injections of stem cell stuff. Um, I'm not sure if I answered your entire question.
The second one was about cortisone. Do you still recommend that? Is that still something you see?
Yeah, yes, it in the core area where these muscles merge, it tends to be a very forgiving area, and I think it's really more the articular cartilage in the hip that takes the hit rather than the labrum itself, which is fibrocartilage, and the there's a fair amount of data about steroids eventually causing problems in the hip joint and in other places too. It's more the pure cartilage as opposed to the fibrocartilage. Um, but there's also a lot of work done with just local anesthetic, saying that's caused problems too. But then you have to look at the model and stuff, and most of those studies were done in mice and rats, and how much applicability is there really? And but I think we have to look at all that stuff with a discerning eye.
And one more last question before we call it a night. What is the likelihood of re-injury after surgical repairs?
For these core muscle injuries, it's less than 1% in terms of those same muscles. It's which is great. What's much more common though is scar tissue breakup. We have a 3 and a 6 week protocol, usually a 6 week protocol, but we do pull out the 3 week protocol a lot. After 2 weeks of healing, it's very unlikely um, to re the injury is very likely to re-injure. I guess that I'm not sure that flows, but but we start them on our rehab program starting the next day, and just like with total hip operations, we start using the muscles that you're going to be used, and we get them back, swinging a bat or throwing a ball and getting on the ice if it's a controlled situation really early, and we want to get back to their sport really early, and that really helps them to prevent scar tissue that's going to hold them back. And they'll you want them to go through the scar breakup stuff, so they'll be feeling these tweaks all along, and it's really important for them to reverse what their natural reaction might be and keep them going. And don't rest them for day two. It doesn't take very long for that scar to reform, and then it gets thicker. So you want to keep on being consistent with the employing that activity-based rehab. The other thing is actually just gentle massage turns out to be really important. Just gentle, dull, blunt massage just allows the healing tissue to be smooth. But you got to stay away from any type of Graston active release stuff in that post-op period, and usually for like 6 weeks, because they'll be working. The athletic trainer, physical therapist, will be working right where I work, cutting through some of these sheaths, which is in the same area, and that's going to create more bruising, more scarring, because basically what I'm doing is denuding the muscle, and the fatty tissue sticks to the denuded muscle, and that's where the scar tissue breakups are.
On behalf of AMSSM, I'd like to thank you very much, Dr. Meyers, for the awesome and enlightening talk. I'd like to thank all the folks that came tonight to kind of listen as well. Thank you very much. We look forward to seeing you back next week for the next lecture. Thank you.
It's a pleasure, a privilege. Thank you.